Hello, everyone. This is Emily Yu with the Build Health Challenge. Thank you so much for joining us for today's webinar, looking at the Healthy Home Des Moines case study. I just want to let you know we're going to give folks 1 minute to finish logging in, just so we can be respectful of everyone's time, but give folks a chance just to pop in as I see our attendee number quickly climbing. So we'll be back in 1 minute. Thank you. All right. Welcome, everybody. Welcome again. This is Emily Yu, representing the Build Health Challenge. I'm so honored to have you all here today joining us to learn more about the Healthy Home Des Moines project with the Build Health Challenge. And I'm glad to be joined today by several special guests who were the team to actually implement this project. So I'll introduce them in a moment. But just want to make sure everybody is in the right place. We're here again to talk about a case study that was recently released. And I'll just go ahead and advance. So you can see here, the case study is currently available at buildhealthchallenge.org in the resources section. It is the first of 7 dynamic cross-sector collaborative stories about groundbreaking approaches to transform health in America, really moving resources, attention, and action upstream to tackle the root causes of chronic disease through the Build Health Challenge. In these case studies, you'll learn about everything from healthy living, food systems, healthy housing, and community revitalization, the techniques folks used, the collaboratives and cross-sector nature of the collaboratives, and what they learned, and how they applied a number of strategies and approaches in these dynamic communities. So I encourage you, if you haven't already, to check out the case study, and we'll have more coming throughout the rest of this year. And if you're already on the Build Health Challenge email list, you'll certainly get notified. And if you aren't already, feel free to sign up for the free newsletter at buildhealthchallenge.com. So my special guests that I alluded to, we're really lucky to have with us today Susan Minnick from Mid-Iowa Health Foundation, Eric Burmeister with the Polk County Housing Trust Fund, and Matt McGarvey from Telligen Community Initiative. These folks were integral not only in the first cohort of Build and the Healthy Home Des Moines project, but also the current second cohort. And Suzanne and Matt are also both current funders of the Build Health Challenge. So we couldn't do this work without them. So before we really jump in, and I'll share a little bit, we're going to do 2 quick polling questions. So bear with me as we attempt to use the GoToMeeting poll tool. I'm going to ask you 2 questions just to get a quick sense of who is on the webinar and what you hope to learn, because we really want to guide the conversation and discussion around what you want to hear. So after we do that, I will spend just ever so briefly a few minutes to tell you about Build and sort of level set about what the Build Health Challenge is. And then I'm going to turn it over to Suzanne, Eric, and Matt to share a little bit more about the actual project. But really, we plan to spend the bulk of time really engaging in your questions and what you want to know. So I'll just flag really quickly, there is a questions box on your little control panel for the GoToMeeting. Feel free to type in any questions throughout the webinar, and we'll try to answer as many as possible, and or you can use the chat function, but the questions will be where we primarily go. So let's check out this polling tool. So the first question is really about just what type of organization do you represent? So here, if you go to your poll function, and it's in the little control panel, I don't know if you see polls, and you pop down, there's just 2 questions. I'm just asking folks to answer, what type of organization do you represent? And let me hit launch here. All right, let me see here. So let me see if you all see that. Great. Go ahead and answer that. You should see that on your screen right now, and you can pick more than one option. So we'll give folks just a second to respond. All right, so let's hit close on that. So I don't know if you all can see, but basically we have 49% on the webinar are from a nonprofit that's more community focused. 18%, and it may be overlapped, 18% are nonprofit with a housing focus. 27% are representing hospital and health systems, and 11% are representing a for-profit or other group, with 76% having completed the poll. That's great. Thank you guys so much. I think we have a really good mix of folks on the line today. So the second question I'm going to ask you all, and the final one, is what do you hope to learn from this? Both the case study and the webinar, so you can sort of broaden it, because we do want to tackle some of your questions later on, but sort of steer our answers into what's going to be most helpful. So here you'll see some suggested answers. Feel free to pick more than one if you want. Essentially here, we just really want to know what you're interested in and try to guide our questions. So take a moment. Great. Okay, so let's close that. So here, of the ones we presented you, we have 42% looking for intervention specific to pediatric asthma. 70% are looking for how healthy housing can transform community health, 70% are looking at how to collaborate across sectors. 42% are interested in about the build framework, and 12% are others. So I do encourage you, especially if in that 12% category, to feel free to pop in any questions in the question panel, and we'll definitely try to specifically address those. Okay, so thank you guys. That's really helpful, especially for our team that's going to dive in a little bit deeper. So for those of 42% that were interested in build, let me just ever so briefly tell you a little bit about the Build Health Challenge. Essentially, build really is based on this premise that, health really isn't made solely in a doctor's office, right? A lot of it has to do with where you live, work, and play, really the social determinants of health. And again, those upstream factors that I alluded to earlier. So on that premise, about 3-4 years ago, there were 5 funders who grew to 12 over the last 3 years, who really put together their resources, their knowledge, their assets, their networks to say, you know what, we can work together to move resources, action, and attention upstream to help communities and work with them in a cross-sector, community-driven way, really drive change in community health and sustainable change at that. What's so great about this, collection of funders is that you see national and regional funders both represented, and it continues to grow in terms of interest in supporting the work that communities are doing every day in communities. So you'll also see that this is our mission statement. We're really trying to contribute to the creation of a new norm in the U.S. As I mentioned, the multi-sector, community-driven focus, and really it's all through a health equity lens. And the work that we do is really rooted in what the communities want to do. So you'll see here, build is really a framework, right? So we loosely define and loosely structure what and how build is. But really what we focus on are these pillars. So you have B for bold for systems change, policy change. You have U for upstream, with really this look at social determinants of health. I for integrated, and really that's where the cross-sector nature comes in. Build in and of itself, and you'll see this represented in the Healthy Homes Des Moines team, has to have a community-based organization, hospital or health system, as well as a local public health department working together. They come to the table from the get-go with Build. And then we encourage and support other partners as well, like chambers of commerce, school departments, police departments, et cetera. It goes on and on. But that group sort of tailors their backbone team. L is for local, and that's really at the heart of being community-driven, having community leaders at the table. And D for data-driven, really focusing on and using data in real time to inform and grow the work. And again, all of this is rooted on a basis of health equity. So we're not really prescriptive about how the sites use the build framework, but we do encourage all of them to employ each and every one of those pillars in a meaningful way. And this gives you a quick snapshot at some of the issue areas, the projects, the types of things folks have been working on. Everything from tobacco control to transportation, maternal and child health. And again, today you'll of course hear the connection between health and housing, which is so critical in so many communities across the country. And my last slide before I hand it over to Suzanne is just a quick snapshot of what Build has been able to do to date and really has had the honor to work with all of these communities to date. So over the last 3 years, and again, we're in the second cohort, each one has run about 2 years. We have had the privilege of working with with 37 communities in 21 states and DC, and we're continuing to grow. We're again very early on, and the excitement around Build is really in that the communities tee up the ideas and the challenges that they see as pressing, and we're really honored to be a partner in how they move forward in terms of the resourcing, the sustainability, how they look at policy, data, etc. And, we try to work with each site, and you'll hear this from Healthy Home Des Moines, in addition to not only building a peer network among these 37 dots and still growing, each one, although they may represent a different issue area, what's so exciting is that they're working together to learn from each other and with each other about how the build principles really intersect with their work and how they play out in the real world and communities. We by no means have all of the answers, but we are trying to learn from each of these, and that's why this case study in particular, being our first out of the gate from the first cohort, has been a really eye-opening experience in terms of really consolidating the learnings, which you'll hear about as I turn it over to Suzanne. So thank you so much for your time. And again, I encourage you to put any questions you may have in the question box, and we'll get to those at the end. So Suzanne, I'm going to turn it over to you.
Great, thank you. As Emily mentioned, my name is Suzanne Minnick, and I have the privilege of serving as President and CEO of Mid-Iowa Health Foundation. As Emily just shared, the Build approach really provides very meaningful guideposts for any organization or coalition venturing into this type of work. And so we thought it was important to begin our section by focusing and sharing on the two initial drivers from that Build approach for Healthy Homes Des Moines. And they were local and upstream. So as a private foundation, Mid-Iowa Health Foundation was looking to invest in efforts that were addressing those upstream barriers to children's health. But I think it's safe to say we were focusing a lot on barriers to access to care. So things like transportation and translation, et cetera. And so it was a number of years ago, I had the privilege of being in a meeting with a grantee. And the grantee had brought along a mother who was being served in this project we were investing in. And the mother pointedly turned and looked at me and said, "Please know how grateful we are for this help, but please understand my son will continue to be sick no matter how many times I bring him to the doctor if every day we are coming home to no heat and cockroaches and rodents." So you can, I'm sure, appreciate that brought this whole idea of upstream to a whole different level and meaning for our foundation. And it became immediately clear that I needed to draw in others who knew more about this topic or a different approach to our work. And so in a minute, you're going to hear from Eric Burmeister, but Eric, as the president of the Polk County Housing Trust Fund, was the first person I called. Help me better understand the impact that substandard housing has on the health of our children and families. And then quickly we brought in Rick Cozen, who at that time was the director of the Polk County Health Department. And as we look deeper, we did indeed find that the prevalence of asthma in Des Moines' poorest neighborhoods was twice the rate of the state as a whole. And that, as you looked even further into some of the Medicaid data, that nearly 10,000 of our Iowa Medicaid members ages 2 to 12 sought treatment for health diagnosis for asthma, and that at that point it was generating a cost line item for our state just in the Polk County area of $1.3 million. So there seemed to be opportunity there to bring in more dialogue, and that we can do better than this. So Emily, if you could move to the next slide. So it's important as we think about that local and upstream to tenants to then note that at the same time we were beginning to have this conversation, there was a really robust grassroots initiative taking shape in our community among 3 of what I would describe as Des Moines' poorest neighborhoods, and it was called Viva East Bank. And residents were coming together, and this map is an illustration of these neighborhoods. They were coming together to share and prioritize their biggest concerns for their community. And as we listened to them, substandard housing quality was among the very top of that list. And this map shows kind of the hot map zone of those poor quality of housing in those neighborhoods. And Emily, if you could move to the next slide. This is a quick just overview as we talk about Viva East Bank, but this is our urban core. A little bit more about the population and median household income. It shows here that there's a 35% white in the urban core. It's probably helpful to note that that number changes to 77% when you go citywide. So there is a diversity and a richness to this community that we wanted to really pay attention to. So as this issue continues to expand, Emily, you can move to the next slide. It's the more questions you ask, the more you realize all that you do not know. And so health and housing then quickly began expanding, understanding we needed to bring our hospital systems in. There's one thing to look at Iowa Medicaid data, but we really needed to know what our hospital data said, really how many kids are suffering from asthma-related illnesses in these neighborhoods, and what are some of the cost drivers of that diagnosis. So we worked with them, and then my other 2 presenters will share more on how some of these other partners have come into the fold as we continued our conversation about how we can do better and formulating a response and the necessary structure to respond to this very clear need and opportunity for our community. So Emily, next slide. So that is really how Healthy Homes Des Moines began to take shape. And it was as we were developing our formulated strategy for moving forward that we then learned about this Build Health challenge and decided our hope for what we could do in this community very perfectly aligned with the Build Health strategy and goals. And so with that, I'm going to hand it over to Eric to talk more about what this actually has looked like.
Thanks, Suzanne. In fact, the Build Health Challenge not only aligned with the kinds of discussions that we had been having locally amongst ourselves, but also gave us that additional leverage particularly to go to the health systems. And there are 3 health systems in Des Moines. And am pleased to say that all 3 of them participate and are partners in this particular collaborative, but gave us the opportunity to go and say, listen, if you are willing and think this is important enough to be a part of, then if you are willing to put your resources into this, then we have found a way to leverage those resources with some national foundations that are willing to match your resources dollar for dollar. So if you like to go to the next slide, Emily, what we did then was to begin to figure out what this can look like in terms of an actual on-the-ground intervention. And so what you see in this slide is just really a very simple line graph of how this particular intervention works. One of the things that I want to, highlight, because it really is foundational to what we do, is that number 1 shows that this program does require a referral from a medical provider. So this is not a program where you can self-refer, where a family can self-refer, or where it becomes a sort of first come, first serve basis for an intervention. And that'll become more evident, I think, as I talk about the trust fund's involvement, because that was a huge sea change in the way the trust fund operated and the way most housing interventions operate. And so it required us to sort of re-examine what it was that we were doing. But so once the professional referral has been made, that means then that different organizations providing different services and different expertises enter in to a relationship with that household or that family that not only are quite robust in terms of their, I guess, investigation and education of the family's needs, and particularly the child's needs, but also a review and a inspection of their home to determine whether or not there might be anything environmental that is exacerbating the child's condition. If there is, and interestingly enough, there isn't always. It's not a situation where you can go or would expect to go into a home 100% of the time and find something that needs to be remediated. So, but if there is, and if the professional inspection turns up something, then that repair is made or remediation is done at no expense to the family. And because we are a means-tested program, that means that you need to meet certain financial requirements. The work is done at no cost and without any expectation that it be paid back. Again, the advantage or the return on the investment to the community is the improvement in the child's health. And then once the work is done, there is continuing ongoing follow-up with the family to determine how the child is doing, and also to provide any additional support that's necessary. At the same time that a family is, I guess, released from the program or is finished with its education and or remediation, supplies that like HEPA vacuums and cleaning materials are left with the family to make sure that that the kinds of lessons that they've learned and the things that have been changed in the house can be maintained. So the other thing that I think is important about this is there also is a circle back through this system to the original referring source. So the fact is that if that happens to be a doctor, a social worker in a hospital, a school nurse, reports are given not only so that those folks can determine whether there's been any return on investment to the medical system in terms of repeat visits, but also so that they know that the referral was followed up on. You can go to the next slide, Emily. So what we've done as we take a look at the program, you can see on both ends of this graph, you can see long-term and short-term health impacts. Those are the kinds of things that you would expect on a program that was focused on pediatric health. What you wouldn't necessarily expect to find, but which are clearly collateral benefits and are some of these upstream indicators. In the middle, you'll find we're taking a look at what school absences look like for these students after, or I should say post, post remediation or post engagement with Healthy Homes. We're taking a look at whether or not parents are missing fewer days of work because they're not sitting in clinics and emergency rooms with their kids. We're taking a look at whether or not we are making any serious improvement to the built environment in our inner city neighborhoods when we do these sorts of remediations. And finally, we're hoping to help the community better understand whether or not, or understand the, I guess, the cost, the total cost and the true cost that pediatric asthma has on the community. You can go to the next slide, Emily. So really, this is just a quick rundown of the eligibility criteria for the program. I probably should have put this a little earlier when we first started talking. But again, the first slide shows that this is not a self-referral program. You have to have a diagnosis from a medical provider of either asthma or chronic respiratory disease. The child in question has to be between the ages of 2 and 12. The geographic area is limited to the city limits of Des Moines. We do continually have questions from our suburban communities on whether or not there is a possibility for future expansion. I will say that the next slide, which shows a required income of 80% or less of area median income, does in fact exclude any sort of meaningfully large participation in our suburban communities. Des Moines, like many urban areas with a large suburban population, the vast majority of our low-income families live in the city of Des Moines. You can go ahead to the next slide, Emily. So you can see that one of the things that we did when we started, and I know Matt will talk about this a little bit later in the presentation, we did provide, and it's a proprietary tool that we built from scratch, which also Matt will talk about a little bit later, as a way to manage this project. So we are in the cloud. All of the information regarding the properties as well as the families are kept. Folks that are involved in the project at various steps along the way, whether they be referral, whether they be inspection, whether it be education, or actual the team that does the remediation to the house, are able to get into this this tool and determine not only what needs to be done next, but what has been done already within the context of this particular family. You can flip to the next slide. I know we're sort of running a little bit short on time here, but there are some demographic information here that I think is important for you to understand. You can see that the largest percentage of our referrals are to folks who rent. You can see that the vast majority of our households, the children are covered by Medicaid. And you can see that the vast majority of our referrals come from the health systems. So in terms of numbers, for the first 2 years of the program, we had 137 referrals. And for this last year, the third year of the program that ends the end of this month, we've had an additional 47 referrals. So velocity is meaningful. It keeps us all busy. So far, we've spent about $250,000 in remediating homes in those nearly 3 years. The average cost of remediation per home is right around $5,000 to $5,500. So that's just a quick look. I'll turn it over to Matt to talk a little bit about some of the initial results that we've seen from the program.
Thanks, Eric. This is Matt McGarvey, and I work as the Executive Director for Telligen Community Initiative, and we are a regional funder that provides health-based funding support in 4 different states. But Iowa is home, and we take great pride in what we're doing here locally. And this project is so emblematic of the things that all 3 of our organizations are trying to be a part of, that creates not just interesting but meaningful linkages between different sectors to advance health in some new and different ways. And as Emily shared at the start, this isn't just about what happens in a clinical setting or in an office setting or in a hospital setting. Obviously, this is something that shows this is where you live and where you work and where you play. And this project is a big part of that. From an initial results standpoint, we still feel like we're early in the game, even several years into this work. But the number of days that children are reporting missing from school due to asthma has been reduced from twice per month to less than 1 time per month. I suppose on the surface of it, that doesn't sound like a lot, but start thinking of that over a 180-day school year, and you're at a significant higher attendance rate for the students that were being touched by this. It avoids a great learning loss, and it really allows somebody to take full advantage of an educational opportunity that in a meaningful way that they might not have before. Meaningful and significant greater understanding by both families, adults, and children of ways to manage the condition of asthma and self-manage that a bit better. And hearing that both from the clinical side of things, but also the home remediation side of things, so that one isn't continually exacerbating the other, is probably the greatest single gift this project brings to bear. Not at all to be ignored, the idea that children are averaging 6 or more symptom-free days a month, which you stop and start to think about that, and just the number of livable days that you have, that's very significant. And it's equally significant, but something where you hope that you're doing something that doesn't force parents and families and caregivers to choose between employment and their children's health, reducing by half the number of days that parents are missing work. And the exciting thing that can do from just an ongoing employment standpoint and livable wage standpoint is not something I think we can overstate. Emily, if you could move to the next slide. So a lot of this is emblematic of somebody like Lucas, and who's age 3 in this picture. There's countless examples like this within this project and within this kind of scope of work. But the idea that Lucas's family was one of the early beneficiaries of this work, and one of the first families to have remediation work done on their home, Lucas's family had experienced upwards of $80,000 worth of bills, insurance, hospital-based bills for care that had been provided in that space, largely due to his asthmatic condition. Step in Healthy Homes Des Moines and this project and this work, about $8,000 worth of home repairs, largely representing a new roof, is what our project helped to bring to bear to Lucas's family. So compared to what Eric shared, slightly above the average cost that we would have been experiencing in terms of what's been provided to families, but not significantly higher than that average. And at the 6-month point after post-intervention, Lucas had not had any days back in the ICU for what was largely being driven by the condition of his home. So his asthma care had been much better improved. And again, not to break our arms patting ourselves on the back, but that sort of connection between the home setting and the clinical setting just simply would not have happened without this kind of work or in this sort of project. And so the efforts of Healthy Homes Des Moines to create a closed loop where that's concerned, again, we just feel like can't be overstated. In terms of, Emily, if you could go to that next slide, and I promise we're almost done and ready for questions, but in terms of looking forward, we feel blessed to have had a second bite of the apple, so to speak, of Build Health Challenge funding support for the Healthy Homes Des Moines based work. And again, still also feel like we're early on in what we can do as we grow up here. But the efforts have been meaningful in terms of what they've provided to families from just lessening the burden of childhood asthma, increased home mitigation efforts that might not have happened at all or wouldn't have happened in this coordinated way. Otherwise, it's one of the things we're looking at doing, and it's easier said than done perhaps, but what can be done on behalf of homeowners and tenants as it might relate to housing inspection, housing policy, local ordinances that can help bring this story to bear or make it easier for this very type of work to happen, and focus on the upstream social, environmental, and economic factors that can have an influence on health in a region like Des Moines. We do feel like this is something that's very transferable and scalable, both up and down and through different size communities. And then spending some fairly significant time trying to figure out how to take this beyond philanthropic support. How do you monetize this type of work and engage our Medicaid managed care organizations in helping sustain these types of efforts? It's not, we'd be remiss if we didn't bring up during the course of this work, our state moved to a Medicaid managed care environment, and that creates some interesting challenges, but it also creates some interesting opportunities in terms of what a project like this can mean to not only the end users and the families that are on Medicaid, but what can we do, what can a program like this do to help the MCOs better assist the very clients that they're trying to improve health status for. I think one of the last slide we'd bring to bear would be just one of the barriers or things, blessings and curses, I would say, with a project like this is being able to collect and share and aggregate, catalyze meaningful data around this type of work. To that point, when Eric brought up the idea of creating a homegrown system or from the ground up system to monitor this work, that's probably both a blessing and a curse, and it's created some interesting challenges for us as we've moved forward. One of the really neat opportunities, it's not completely because of Build, but it certainly helped. We've been able to have the advantage of being selected as a TA recipient from Green and Healthy Homes Initiative to assist us, not necessarily so much in the implementation of this type of model, but how do we speak the language of reimbursement, third-party payers, to really bring this data to them in a way that's actionable, and collect and tell our story in a way that's meaningful to them, but also something that's useful to them, and that this work can start to show an ROI return in a way that it goes beyond the feel-good story, but it actually begins to save money, show how this is both improving care and taking money out of the system, so to speak. So and using a data platform that Green and Healthy Homes has brought to bear is something that we're in the midst of evaluating and transitioning to again, better tell this story as we move forward. So with that, I turn it back to Emily and all of us to thank you for taking the time to listen to our journey and our story today. It's ongoing. We're several years in, but we're still at the early stages of this work.
Thank you so much. This is Emily again. Thank you all. Wow, wealth of knowledge and experience for sure, and condensing that case study into a quick, 30, 40-minute little summary there. So thank you all, and thanks to the attendees for, keeping the questions going. I see a bunch have been submitted, so again, we've got about 20 minutes to go through some of those questions, and it's not too late to submit in the question box on your control panel. So Suzanne, Eric, Matt, thank you. I will just sort of shoot out some questions generally to the three of you, but feel free, we can divide and conquer because there's several in the queue. The first question I'll start out with is from Lori. Lori asks, how did you measure or quantify, quote, substandard housing? So I think that's sort of a fundamental and preliminary definition that Lori's looking for.
Sure. Lori, the Polk County Assessor has a tool on its website that uses a number of things regarding the condition of a property and actually does that by address. So the geomapping that you saw earlier, that's taken directly from the Polk County Assessor's website. And there are a whole lot of factors that go in there, including a visual exterior, mind you, not interior, but a visual look at all of the properties.
Great, thank you, Eric. And this question comes from Abel. Abel asks, how are follow-up reports for referral sources generated? Are there specific metrics reported?
So we have a series of post-evaluation. So we have a home visitor that is part of that initial home assessment team that goes in, and she does both a clinical asthma assessment, an environmental, and assesses the other potential referrals that that family could benefit from. So we've got a pretty extensive initial assessment tool, and then an evaluation tool that the home visitor follows up post-intervention or post-visit. And so most of that information then is referred back to that referring provider. And things like, do you feel more informed about the asthma diagnosis? Do you feel like you've got additional resources to better manage? And things that Matt and Eric mentioned around fewer days of missing school and missing work. So those are the types of things that are then brought back to that referring health provider.
And maybe better said, available to that referring health provider, because the current system that we built and are operating with is almost like a mini medical file. So the fact is that all of the information that's collected about this particular patient through the intervention process is in that client's folder or file, and a provider or someone on the provider's behalf can access that, and there's nothing that is hidden. A lot of information in there, so it may be that it's one of the limitations. There may be something specific that a provider is looking for, and he or she may have to dig through some additional layers of things they're not interested in, but the information is there.
Great, thank you. And Matt, this question might go to you. Melissa asks, the results that you shared and the outcomes that you're looking for in terms of ROI, such as, the school days that you mentioned, employment days where parents don't have to miss work. She's hoping for a little more understanding or just depth of, how you guys are looking at ROI and sort of coming up with some of those calculations. Do you have any advice or other, feedback for someone who's looking to calculate ROI related to pediatric asthma and housing?
Well, I would tell you that that's maybe the golden ticket here in so many different ways, but I think that part of what we're trying to do, I'm not turning the mirror back to the person asking the question, but I do think it matters what people think locally and what can happen with a project like this so that it attracts the attention of payers, those that are in the housing sector and those that are in the more traditional health sector. I think that's been the most valuable thing from my standpoint related to our small piece of this puzzle and the work that we're bringing to bear is how do you translate those two worlds? You can have really good intentions of wanting to do work together in that space, but those are not sectors that have unfortunately necessarily worked together all that often. So trying to figure out what those success metrics look like, and also figuring out we shouldn't be doing this in a vacuum. We need to incorporate payers into that mix so that it's meaningful to them. We could create a great infrastructure, but what does that MCO world, and even I would say too, what can hospitals do from a more creative standpoint around community benefit investments? All sides of those equations, I think, can be things that this type of project could have success metrics built around.
This is Suzanne. I'll just jump in and say I think that's one of the that is the key reason of our work right now with our managed care organizations is really they have to be at the center of what is the true cost of the treatment that our kids are experiencing. We had worked with our various hospital systems, but we have 3 hospital systems that are all within a 5 to 7 mile radius from one another. And so while you could pull pre and post results from one system, the potential that child had visited other systems was very high. So our managed care organizations have a much better idea of what that true pre and post medical cost looks like. And that's not then getting into the cost of missing school, etc. But that is our primary goal for this phase of the work, is to better understand those true cost numbers and drivers. So we're not there yet, I suppose would be that answer to that question.
But we're slowly but surely making progress, thanks to you guys. So another question came in that might actually be a nice dovetail in terms of making sort of, instead of the ROI and that sort of spectrum as an outcome, let's go back to the actual remediation that's happening. Danny cited the stat that I think Eric mentioned. The average cost for remediation is between, I think it was $5,000 and $5,500 per house on average, and then Matt referenced the roof. So Danny's just curious, what measures are done in remediation, and I think looking for just more examples of the types of things that qualified and were actually executed.
Yeah, I think we have put in more exhaust fans than have probably been installed in quite some time. So the fact is that when folks and healthy homes inspectors get into houses and start looking around and remembering that most of our remediation has been done in single family homes as opposed to large multifamily complexes, what you find is that there are no exhaust fans in the kitchens or bathrooms. A big issue in terms of asthma triggers. You'll also find that wall-to-wall carpet is a huge collector of just general crud that triggers kids' asthma. There's also another remediation step that has nothing to do with actual bricks and mortar repair, but the number and the education that our home visitors provide around companion animals is well, it's what you expect. I mean, you have dogs and cats sleeping in asthmatic kids' beds. It happens. It's not surprising because Suzanne likes the story. I'll tell you that the best companion animal story that does speak a little bit to education was a young sister decided to rehome her favorite guinea pig because it was very clear that that guinea pig was having an adverse effect on her little brother's asthma. And so those are the kinds of stories, and those are the kinds of things that happen. But the remediation, I will tell you, we have spent well over $40,000 on one house. So there are some outliers where we found a house that, because of years of a leaky roof, had literally black mold in every single room. Those are the outliers. Most of the time they are exhaust fans, they are a replacement of wall-to-wall carpeting with hard surface floors. It's not as frightening as what we thought it might be early on.
Thank you, Eric. And we had just a handful of questions come in, and I want to be cognizant of time. So I'll throw these to you guys sort of in a round robin style, if that's okay, but we'll try to get as many of these done as possible. And I apologize, they might not flow as neatly as I had hoped, but I'll try to get them all answered. So we have here another question that came in. Are there any healthy home programs that focus solely on senior citizens? Do you guys have a quick answer for that?
I'm not aware of any at this point.
I am not either. Just from a different perspective, if you have a Rebuilding Together chapter, they are also one of our partners. If you have a Rebuilding Together chapter in your community, you may want to check with them. They are quite involved in things like handicapped entrance ramps, getting rid of trip hazards, installing grab bars and those sorts of things.
I'm not aware of any either, but I would say that this, maybe not soup to nuts, but this does provide an interesting opportunity, I think, to begin to talk to the Habitat world about what could be done in their space, or connecting their traditional program model to health and social services in some different ways as well.
Terrific. Thank you all. All right, another question that came in from Manuel. Manuel asks, are you tracking any data on health outcomes based on housing interventions? So as I read this question, it's about maybe some of the actual metrics or indicators that you're tracking that link health outcomes based on housing interventions. Any suggestions there?
Well, I think that's one of the things that Suzanne was alluding to when we talk about those traditional returns on investments for decreased medical usage. Yes, we do, and they look promising. But what has to happen is that for every intervention that we do, someone from the medical provider has to go back and pull that child's medical records and determine whether or not there have been, how many emergency room visits there have been post-intervention, if any, how many clinic visits, if any, if there were any, what were the visits for, were they asthma related? What we find is that when we look at them like that, yes, it looks promising, but it really is difficult to really put those out there in public as something that you would want anyone to depend upon. Because as Suzanne says, that same child may have been to the emergency room at all 3 medical systems or the other 2 medical systems. Many of these folks, unfortunately, do not have medical homes.
All right. Yeah, it's a pretty multifaceted sort of situation you've got going on. So thank you for trying to unpack that a little bit. We're getting down to the last 2 questions that I see here, and then I've got a sort of closeout question for you all, but we can still sneak in some more if folks have them. This question is one related to the payer organizations and possibly hospitals and foundations in terms of who is your point of contact. So this person asked, in what professional capacity or what, title might this person have at a payer organization, a hospital? For example, could it be community outreach or CEO? And for example, the foundations, is it the program officer? Who is the sort of lead contact that you all would suggest? And they specifically asked for payers, insurance companies, foundations, and hospitals.
I would say really across the board, we've worked very hard to establish those initial relationships and conversations with the CEO or decision-making maker level. We've been very privileged that we have a community that between all of us sitting around this partner table, the relationships we've been able to connect. And so all 3 of our hospital systems, the CEOs were the ones that we initially went to get their buy-in and approval. Now working with our Medicaid managed care organizations, we've been at the CEO level, and for our foundations and really our nonprofit partners, they all started because this is a new approach. It is a new lens. And so I think we've found it to be beneficial. I wouldn't say it's the only way at all, but we have found in our situation that it's been beneficial to have those decision makers buy in and input from the beginning.
That's great, Suzanne. And a couple more people snuck in questions, so let's see if we can tackle these. Jessica sent a question that's a pretty interesting one. She asks, in looking at pre and post medical costs of the population, has there been any evidence that costs have increased due to the population being able to now adequately connect for regular disease management? What are your thoughts there?
I don't know that we could answer that question adequately. I'd say anecdotally, no, except for maybe a couple of occasions. But really, the main cost drivers, are hospital stays and ER visits, and those we have seen definitely go down. Where we've come into issue, and this, I think we've tried to be really transparent about this, is our health systems pull different codes and even from one another, or going back to even know what those initial cost drivers were and then what the savings might look like. So I don't think we could say for sure that there haven't been occasions where that has gone up, but I would say for the most part, our preliminary data says no, in fact, perhaps even cut in half.
I think this is where we really score if we're able to get the third-party payers, in this case the managed care organizations, on board, not only as a referral source, but also as a follow-up in terms of a client's total health picture, because they would be the ones that would have it, because they're getting all of the claims regardless of where the service is rendered.
And we're getting close to
we're getting close.
Getting some of that data. So
and a different maybe spin on that question though too is the map that Emily showed early on in terms of the dots around the country where Build has active projects or interventions or projects that had recently completed. In this second wave or second cohort of funding, correct me if I'm wrong, Emily, but there's about 19 or so projects that are happening nationally, and a good 4 or 5 of them are in this space of home remediation or the interplay between housing and health. And so I think as much as our story hopefully resonates, there's others that can be brought to bear as well to figure out regionalized or other examples. There may not be a perfect way to do this, but this is an example that we feel is beginning to have an impact. But there are others that I think you can draw upon to do something similar where you reside and where you call home.
That's right. Thank you, Matt. And with that, I apologize. We're not going to get to the last question, but I'll try to connect you with the speakers over email. But I just want to say thank you to everybody so much for signing on. Our contact info is there via the website and Twitter. Just a reminder, in the chat section, you'll see a link to the actual case study. It will also be on the follow-up thank you email, so you'll have all of this at your fingertips, including the recording. But stay tuned because there will be other case studies coming out in the coming months. So if you're on the email listserv for Build Health Challenge, you'll certainly get first notification of all of that. So again, thank you so much, and we'll all continue this fight together to transform health in America. Thank you and have a wonderful day.